You've been recommended to have a Brostrom Lateral Ligament Reconstruction. The reason we do the surgery is because the ankle is unstable, meaning it goes over on uneven surfaces too easily. It's a problem because obviously you fall over, it can cause pain, and it means you lose confidence in the ankle. The other problem is if you have repeated ankle sprains, it does predispose to ankle arthritis. So we want to minimize the chance of that. There are other treatments you can try before surgery, and some of them you may have already tried. Physiotherapy is a valuable tool in trying to manage ankle instability. You can't strengthen the ligament, but what you do is you make the surrounding muscles stronger so they can help to stabilize the ankle. Also, you train those muscles to fire quicker when your ankle feels like it's about to go over, so that they again quickly stabilize the ankle for you. It does work in about 50% of cases, but in some patients, when they stop doing the exercises regularly, or just because the ankle is so unstable, it doesn't help, and that's why you might be considered now for surgery. Other things you can obviously do is, if the only time it goes over is during sport, is to wear a brace during sport, and that will minimize the chance of the ankle going over. Using a brace permanently often isn't a great idea because it does weaken the ankle muscles because they get less opportunity to work. The Brostrom ligament reconstruction is what we call an anatomical operation. We are using your ligaments and we are reattaching them onto the bone. I can find them during surgery, even if they're detached or stretched. What I then do is essentially reattach them and tension them appropriately. To reattach them, I do use a small metallic anchor, which is like a small corkscrew, which has threads coming out of it. And we use those threads to secure the ligament onto the bone. We test the stability on table, and we don't let you leave the operating table unless we're happy with how stable the ankle is. In some cases, in particular those patients who are hypermobile or where the ligament is very damaged, I sometimes add in an additional device called an internal brace, which oversews the whole complex and that way acts like an additional check rein. I don't use it in all cases because it's quite a big implant and it is quite a lot of foreign material to have in your ankle, but sometimes it's needed in these scenarios. The aim of the ligament reconstruction is that once you have recovered from the surgery and the rehabilitation, then your ankle should function like a normal person's ankle. That means that your ankle shouldn't go over just walking on uneven ground or on normal pavements. However, you must remember this is an anatomical repair. I'm not giving you a new Kevlar ankle. If you go over in a rabbit hole or fall off a step, the same way my ankle would buckle, your ankle can still buckle. When that happens, which is obviously now much less often, we manage it usually just by resting it as a normal ankle sprain and things settle. Occasionally, obviously, if that does happen badly, then you may need further surgery, and that surgery is obviously more difficult because you've had an operation before. On the day of surgery, you'll come into hospital a couple of hours before your procedure. On the ward, you'll meet the physiotherapist, the anaesthetist, and the nursing staff. I'll also take consent from you, but hopefully you'll have watched this video and you'll have identified the risks and be familiar with them already. The physiotherapist will talk to you about mobilization after the operation. The anaesthetist will talk to you about the anesthetic, but he also may offer you a nerve block. Now, the nerve block, if he offers it to you, is to reduce the pain. It's not critical after a Brostrom ligament reconstruction, but it will sometimes does help. So that decision is for you and anaesthetist to make. The physiotherapist will, after the procedure, put you into usually a short walker boot. I have an example of that here. The walker boot goes up. This is a very large one, by the way. It goes to the middle of your shin, and with it you're allowed to weight bear. Now you can walk on it and you can full weight bear. We do give you crutches because it's quite nice sometimes to have the ability to not have to put the foot down if your foot is sore. I will keep this boot on usually for about 4 weeks, and usually you can take it off in bed. If you're at rest, take it off. It reduces pressure on the wound. I'll give you those instructions specifically on the day. But you'll have it for about 4 weeks, after which you give you an ankle brace, or we may let you mobilize free. Sometimes after 2 weeks, if you're quite confident and your reconstruction is a fairly routine one, I may let you walk around the house without the boot. We will start. I'll see you at 2 weeks after the operation, when we'll take the big dressings down. We'll check the wound. We use dissolving stitches, so you don't have to have stitches removed. I'll refer you to physiotherapy, which starts around the 3 week mark, and we'll get the ankle stronger. The boot stays on, as I said, about 4 weeks, and sometimes in the longer term after that, you may need to use an ankle brace. What you can do in terms of sports, the first 2 weeks of an activity in the gym is very limited, but you can do core exercises. There's plenty of time to build up your core, and just do lots of sit-ups and other exercises, and you can build up your upper arms. But the legs, you can't do too much for the first 2 weeks. After that, the further rehabilitation is quite specialised and will be done with the physiotherapist. I usually see you around the 6 week mark, and if all is fine at that point, I may discharge you to the care of the physiotherapist. There are risks of surgery, and these are important, and we need to go through them. It is an operation, and all operations have standard risks of infection, swelling, numbness, DVT. Infection rates are low. The scar location sometimes can rub on the boot, so we have to be very careful when we use a boot or when you're using it to make sure the scar is not being pressed too hard in that area. You can sometimes get a bit of numbness on the outside around near the scar, and the ankle will certainly feel a little stiff initially, and we almost want that. I'm often asked, how do I know how much to tension the ankle? I tend to tension it to 110% so that as time goes on, it loosens a bit and then gives you a more natural feeling ankle. It can sometimes be over tightened, and obviously it's an anatomical repair, so as we mentioned, you still can rebuckle the ankle just like anyone else does if you fall off a step or into a ditch, and in those scenarios you could tear the repair. There is a risk of DVT or pulmonary embolus after any operation. This is considered a low risk procedure, and I minimize the risk of this by allowing you to weight bear in the removable boot. Very rare circumstances we use a cast if it's a very difficult surgery or if I'm doing a lot of things at the same time, and in those scenarios, if I've given you a cast, I'll usually give you blood thinning injections. To shower after surgery, the easiest way to protect their dressing is to get what we call a cast or dressing protector. These are widely available online, and you can get it from Amazon, or even Limbo is a company that does it. It acts as a seal that goes over the dressing like a giant bag, but it's better than using a carrier bag or something, because the chance of water going into the dressing is significantly reduced. If your dressings do get wet, you must contact me because we need to change the dressing. If you have further questions about your recovery, do first read the leaflet on my website, and obviously if you have any other queries, then you can always email the office and I'll be happy to answer them for you. What we don't want you to do is come to the surgery on the day of the operation worried. We hope we'll have answered all your queries before that.